Do we ever?
Yeah, I was gonna say, do we
We have
ever?
a general idea sometimes.
General idea.
Sometimes.
Yeah.
Sometimes. So when it comes to musculoskeletal injuries, how much musculoskeletal is paramedic level ALS stuff?
Muscle and skeletal.
Mostly BLS.
Very little, right? So most of this is BLS skills. Do you guys all agree with that?
Yeah, sure.
Did I just maybe set you guys up just a little bit?
Uh-huh.
We're always ready for the bus.
Always ready for the bus, so that's good. I like to take the bus, hit you, back up, hit you again, maybe drag you for a little while. So muscular injuries, so majority of the time they seem to be BLS, but if you don't do your job as a paramedic, you can miss significant ALS interventions. So what types of presentation would you think could lead something, lead a normal broken arm into an ALS patient? Bleeding.
Arterial.
Tear, yeah.
Okay.
Tear with bleed.
So significant bleeding, okay, hypovolemia,
Pain management.
pain management,
Oh, yeah.
depending on ALS, ILS, advanced level stuff, right? Okay, so of all of these things, what's one of the main, so we talk about bleeding, so what does bleeding cause with an extremity? What does that do listen, so A, you have the hypovolemia potential, but what else does that do if let's just say you have a femoral artery or, not femoral, brachial artery injury, right? So you have your loss of blood, but what does that do when you lose blood to the tissues?
They die. So you
Die,
have
right?
death below.
Circulation below.
So what do we do with every orthopedic injury that we check?
Pulse below
Okay, so what happens if you don't have a pulse below the injury site?
the one chance to like remove the
Just
To
with the patella.
remove the site.
So like to position it.
What's that called?
Position of function.
Anatomical position.
Anatomical.
Right? So you have one opportunity to put it back in place, right? Is a lack of pulse a emergency?
Yes.
Yes.
How do you manage that as a paramedic?
It could either because their blood pressure is too low and you don't feel it in the radial pulse, or they're actually just bleeding. And that's another.
Or have a tamponade somewhere.
So there are multiple
Or
things. So
obstruction.
as your assessment, as your history around the event leading up to it, trying to figure out, so it's not just a clear-cut one answer for every single lack of pulse, right? I mean, you can have hypovolemia because they're bleeding out somewhere else and they're just, basically, there's no blood there. You can have a pinch of the artery, which then is something where you fix the anatomical position, right? You can have a fracture there. If there's a fracture there, what do you think is the potential for happening at that site?
Shearing.
Shearing, right? So you have multiple things. So if you end up with, if you're trying to rule out and figure out what exactly is going on at the distal site of this injury, what additional things are you looking at other than pulses?
Swelling.
Swelling?
Color.
Color. Color's gonna be a huge one. What's color gonna tell you?
If there's blood under the skin, ecchymosis.
Okay? And so let's say it's pale and clammy and cold to the touch, but up here it's all warm and tingly. And
No blood
is that bad or good?
Bad.
Sick or not sick?
Sick.
Hybrid therapy or not?
Hybrid.
Diesel therapy.
Well, it's all gonna
Code
be
3 or
electric
code 1?
It's
soon.
good, right? It's good. We're moving electric, right? I mean, that's what, the cities, all cities out there are working on trying to figure out how to reduce their carbon footprint. Drive these $1 million fire trucks to the grocery store every day. Shopping. I mean, I don't wanna say, hey, I got a good idea how you could reduce a lot of it because I enjoy not having to shop off to you and do all that kind of stuff, right? But yeah, so that's a lot of what they're doing because that's where the majority of the miles within our profession are accumulated, is on the ambulance, right? They're on the road nonstop, right? So hybrid therapy, electric therapy.
Ooh, that's confusing. Electric therapy.
Oh, true. Okay, let's go. Let's stick with hybrid therapy then. So when it comes to that, it's a recognition that this is, the only way this is going to be fixed is in the operating room, right? I watch time and time again, young, new paramedics that are being like, oh, well, everything else is stable, this is good. Like, there's nothing really wrong. Yeah, you don't have real good pulses down here, and this is a BLS skill. So we're gonna splint it and we're gonna take you to the hospital, right? So, does this person run the risk of potentially losing extremities because of poor decision-making on your behalf? Yeah, absolutely. And so really recognizing poor perfusion, poor circulation in those extremities, secondary to an injury, secondary to a blood clot, anything like that, is a true emergency. Yes.
So, when you put a tourniquet on, usually you have for 2 to 3 hours. It's like the limb is pretty fine, not having circulation for that long.
Pretty fine.
So I was just wondering how that differs. Does that really differ very much if you're not getting circulation due to a break or something? Besides the fact that there's bleeding in the.
It doesn't. So a lot of it is very similar. You are cutting off perfusion to that extremity, right? If you're putting a tourniquet on somebody, is that an emergency?
Yes.
Right? So it's really, it doesn't change your situation at all. It's still an emergent situation that if you don't get this fixed in an emergent type of a situation, they run the risk of long-term effects. Does that make sense? So there's virtually no difference whether or not you cause the stop of blood flow or if it happened based on the injury. All right.
Would that end up being something like a modified trauma alert?
No, absolutely. So absolutely, this is one of those times where you get on the phone and you're talking to the doc and be like, hey, so yeah, I got this fracture here, but I have no pulses. I'm trying repositioning anatomically. It's now a cold limb
extremity, distal extremity.
Yeah, they're like, okay, yeah, we're gonna probably have orthopedic surgeon there waiting for you when you get there. They're gonna come in with their Doppler, do a quick pulse check, circulation check, take a quick look, maybe an ultrasound, and then.
But you do the modified so that you get the ortho there.
So here's that modified full issue. So we don't have modifieds anymore.
Okay.
The hospitals still have modified, but for us, we do all or nothing.
Okay.
So they've kind of taken that away, and so when we call, we just call for a full. So if it doesn't meet mandatory trauma activation criteria, and we have our throwdown cheat sheet, which one do we use?
Paramedic discretion.
Paramedic discretion, right? So you can call in and be like, hey, I'm thinking using paramedic discretion on this one based on lack of pulse. And 9 out of 10 times they're gonna be like, sounds good, we'll see you when you get here. And then boom, they're gonna go. So we do the full, and then they downgrade it to a modified based on the information.
Okay.
And so they really, it used to be, we'd call in on it with a modified, and then they'd be like, well, okay, well, a lot of the state advisory board stuff was like, we're just gonna make it easy on pre-hospital settings. These are the
Do it or
criteria.
don't.
Because it used to be, so part of like your GCS stuff, they would give you a modified scale and then a mandatory full trauma activation scale. And then, so then, of course, people had a hard time trying to remember multiple things, so they tried to simplify things, being like, it falls in this criteria, you're doing a trauma activation, hospitals have the ability to deviate from the resources that they call. But it takes the pressure off of us of having to determine if it's a modified or a full. So this is paramedic discretion because we can use it every time if we have to. And this is a situation where it's like, yeah, hey, I'm gonna use a modified on this, or I'm gonna use a
Trauma.
discretion on this based on this and this. And like I said, most of the time, they're gonna be like, oh, sounds good. So. All right, so you guys are all good with your anatomy of all your bones, right?
Yes.
What are
At
long
one
bones?
time.
Long.
Good. How do you spell long? L-O-N-G, right? No. Which ones are determined for long bone fractures when it comes to trauma activation criteria?
Humerus.
Femur?
Humerus.
Humerus? No.
Femur. Humerus.
That's just the.
So
Humerus and femur are the only two that are long bones in relation to trauma activation criteria. Now, when you look at long bone definition, are the tib fib and the radius and the ulnar potential long bones that are also put into that definition by Google and Wikipedia and those. Yes, absolutely. But just know for trauma activation criteria, because you're not going to trauma activate criteria on somebody that breaks their wrist, right? Like if they snap both these bones, like ice skating or something like that, you're not going to activate trauma system, right? Because those aren't the types of long bones that the trauma activation criteria is looking for. It's looking for humerus and femur.
Mechanism injury.
Exactly. So why do they differentiate between those? Besides mechanism, think about
The size of arteries.
think about the size of the bones in relation to each other. So you got your radius ulnar versus your humerus. You could put both your radius and your ulnar together, and they're probably going to be about the same size as your humerus, right? So the size of your humerus and your femur take a whole lot of force to fracture, right? So what's up in these regions as well?
Large arteries.
Yeah.
Large arteries, right, that supply the entire rest of the distal line, right? So you have lots of vessels in these areas, as well as it takes a ton of force to break those bones. Do these patients get C-spine? So with fractured femur.
Their pelvis
Technically,
and
yes.
everything is locked in.
Depends what they stabilize the pelvis. Depends on the mechanism.
Say that one more time. Talk about the pelvis.
The pelvis is the joint above the femur, so you have to stabilize the joint above the femur, which is the pelvis, which is including the torso, like even the entire body.
Is everybody tracking? So everything that we do, we're splunting above and below, joint above and below, right? Is this person going to get a C-collar?
If you're gonna do spinal precautions.
If you're going to do spinal precautions, you just go full out, right? Can this person have C-spine cleared?
Yes.
Is a fractured femur
Depending on the
Distracting.
mechanism.
a distracting injury?
Yes.
Yeah.
Is it going to start to become a judgment game with you as a paramedic?
Yes.
Absolutely, right? Have I taken the patient to the hospital that had a fractured femur on just a backboard? Yes, with no C-spine. Did I get chewed out by the ER doctor? Yes, yes I did. And then I explained the mechanism behind it. And then the doctor apologized later. But it's those kinds of things, like you're gonna be put in a situation, the kid was riding an ATV, took the ATV, took a T-bone accident, somebody just, basically his little brother ran smack dab into him. He wasn't even riding, he was just sitting there, but his brother ran into him at like 10, 15 miles an hour, pinched his leg between the gas tank and the bumper of the other ATV, mid-shaft femur fracture, obvious. Is there anything wrong from here to here? There wasn't, right? The kid didn't even fall off the quad. He sat there and he just started screaming, and then they looked and realized that the bottom half of his leg, as they pulled the one ATV off, the bottom half of his leg just kind of went kind of off the foot peg. And they're like, oh. But funny thing happened, what happens when his foot falls off the foot peg?
It's shortened.
It pulled a little traction on it, right?
Yeah.
Just the weight of it. And so he screamed, it falls off, he's like, oh. So what did the parents try and do?
Put it back.
They tried to put the leg back up on the foot peg thinking they're gonna support it. What does the kid do?
Scream.
Scream. But what do they think? They think it's gonna be better to help support it. So now they're like in this middle holding position, like in the dunes, like holding this thing. And so it's just like, you're gonna get to that point. And so we show up and this kid's sitting on the quad still. I'm like, okay. Like, and this was back when we C-spined everybody. Like everybody gets C-spined. I'm so happy that we are no longer C-spining every single person. Half the time C-spine does more harm than it does good. And so I love the fact they're giving paramedics the ability to be able to use a little bit of their brain. The bad thing is we have paramedics from other colleges that are out there, so they're not as smart, they're making poor decisions. And so you just really have to watch some of those other colleges that don't make good choices when it comes to C-spine and not C-spine. Because you guys would never make the wrong choice, right?
Of course not.
Never.
Okay, as long as we're all on that good same page. Okay, so there are going to be times where you're going to make those decisions. It's going to be a judgment call. Think about the mechanism behind in order to fracture those bones. So now, let's say somebody fell off a horse and fractured a femur. Now what?
We got our higher
Higher-
suspect.
Right, so you have a more of a full body assessment / mechanism that you have to really pay attention to. Okay? So judgment calls. I love the fact that paramedics get to make decisions, right? And then your partner is going to second guess your decision, and then you have to stick with your decision, and then your supervisor is going to second guess it, and then you got to stick with your decision, right? Has anybody walked into an interview ever where you're trying to get a job and you give your answer, and they try and like second guess your answer?
Yeah.
Anybody ever have that? Yeah? So those are the most nerve-wracking interviews you've ever gone into, because people are just checking to see how confident you are in your decision-making ability, all right? So when you make these decisions, you have to be confident, and you have to think through the process of being like, oh yeah, nope, mechanism's not there for the rest of the body, this is an isolated injury, and so making those decisions will become easier if you're able to think through it, okay? So it protects vital organs, right? Where are the major vital organs that we're concerned about? Thoracic cavity, right? Is there a whole lot distally? What are the major organs distally that we're concerned of?
Arteries.
Maybe just arteries, yeah.
Arteries, right? Those are the big things that we're worried about. Why do you think we have so many bones around our thoracic cavity?
Those organs.
So think about it. So
And breathing.
if you take a whole bunch of force and apply it right here, take a whole bunch of force and apply it right there, how much force does this rib take?
The majority of it.
How much does this take?
A little bit more, or a little bit
That
less, a little bit
Right?
less.
So the nice thing about the ribs is how we talked about flailed segments in the past. Flailed segments are kind of a decent thing to happen because of the fact that you have a multitude of ribs that have now taken the brunt of the impact versus if somebody takes a shot right here to the mid femur. What bone takes the
The femur.
femur takes all of it, right? And so that's why we have the bigger bone to it, because of the fact that it's the big bone and it has no other thing to help support it, right? Vessels. What are the major vessels that we're concerned about in the distal extremities?
Femoral artery, brachial artery, radial artery.
Arteries.
Anything that has a pulse? Can you bleed to death from any of those?
Yeah.
Yeah.
Yeah?
Sometimes.
Can anybody find a femoral artery? Not on you. Everybody can find it on them. All right, grab a partner, find a femoral artery.
Go.
I gotta find it.
What? You're injured? Are you injured?
I can feel it when I work out.
Oh, but you said you can't, and then you're like pushing like you were like injured or something.
He was pushing you, he's injured.
Who's pushing me?
Lay down. Yeah, just lean back.
There's no way you can check that.
Huh?
don't actually know.
Is it?
Oh, thank you, Andrew.
I think that's review.
So, Noah, hop up here.
I'll go back to the bone for a second.
Yeah.
Ribs are not considered, well, they are considered long bones, but a broken rib is not a trauma activation.
Nope.
But multiple ribs are.
And
Two.
Hey.
Two or more in two more places.
There you go. Basically a flailed segment. It has to create a flailed segment in order to hit mandatory criteria. Like you can sit there and grab somebody and they go, and you're like, and every bone is broken here, but there's no flailed segment. What do you do there?
Stretch them out.
Yep, there you go. So see, that's where you're like, okay, no, doesn't meet mandatory, but you just, poof, that's a lot of creptus, right? There's a lot of stuff that could be going on there. Lots of mechanism related to that. Paramedic discretion is where I roll with that one, right? And so that's the kind of thing that you're just like, that's a lot of creptus. And then you're like sitting there watching, like, please, just give me some sort of like little like abnormal movement there. All right, feet down there. All right, femoral arteries. Trying to find the femoral artery. You're gonna have to lay down. So what you do is you find the iliac crest on the side, okay? Right there, okay? Find mid-shaft femur. Basically, you run straight up the mid-shaft femur. Try and track it all the way up towards the iliac crest. And as you roll your finger kind of down into the iliac crest, you basically you can kind of push down, and you create a little crease there, okay? And with that crease, a lot of times, so it's not comfortable. He's not enjoying it, right? So when you like really dig into it, he really doesn't like it, right? So I watch people do femoral pulses, and they're like in a code. The femoral pulses in a code are great, right? They're just like feeling. I'm like, what are you feeling for? I'm like, are you kidding me right now? Like they're just like. nope, I feel no pulse. I'm like, yeah, no kidding, you feel no pulse, right? Especially in most of the people we go on aren't skinny, healthy individuals, right? So there's a lot more excess mass that you're having to push through, right? So it's almost like you're palpating the abdomen, pushing down in there. So you find the iliac crest, mid-shaft, right in there, and then basically you just kind of push, and then you just hold, okay? And then, the patients really don't like it. It's really kind of funny, okay?
But you don't have to worry about including it because you're gonna feel it. It's included. So you can put it as hard as you want. It's not like you have to be gentle with it. You know what I'm saying?
Right, so that's exactly,
That's not included.
so think of it like, so you have like the V of the pelvis here. So you got your mid-shaft here, here's your crest. So you run your crest, mid-shaft, basically like where the corner of the pocket would be, okay? And you find that groove and you can push right down in there, and you're pushing towards the midline of the body in an attempt to find it, okay? Search around, find your buddy.
And she felt up top and immediately.
You got a lot. Mine was, look at the board. It says laryngoscopy and renovating. Like, you don't need to talk to the
Alright, so I'm just gonna do the quick add skills and just go ahead and do that. If you wanna add a patient age and sex and all that stuff, then you guys can do that.
I only know this much about the patient because we spent an hour trying to find a diagnosis.
Sex.
Or
After you find the femoral pulse, then we talk about sex.
So should I go back in
Because it's kind of
and
like sometimes,
what about the
no, quick add skills for innovation rather than a full patient workup.
like, because she had ropes on her hands.
You can do either, but it's more beneficial if you do a bigger workout. If you take an extra couple minutes to find out how old's the patient, why are they in anti-antidote.
The anesthesiologist.
But you might not be able to do that for OR, but like in the ER, you will. Like, you do an IV, you get all the information. But you're not going to get that in OR. I mean, I got 5 minutes. Hey, my name's Jackson. I'm helping you anesthesia, and then drugs, intubate, you're done.
Right,
All the
but
time you had.
like find out like from the board or from the nurse, like how old was that patient, where are they in
You
for?
definitely, yeah.
And so then that's all the information I was looking for. Not necessarily talking to the patient.
That's true. Which then I can't think back to 6 patients and remember what, maybe, yeah.
That's why a lot of times I'll write it on paper and then go back and add them in.
So all the OR shifts are full through the second week of April.
So that leads us into spring term, then if we don't get 12.
Yeah, so we'll be looking at next term if you guys look at your 12. And then we'll reschedule that. Everyone signed up for 2 labor delivery and 2 pediatrics?
Yeah.
Okay.
Sounds good.
When do those start? What's the first day?
Week from this Friday.
Yeah, you said 27th. I don't think there are
It's
any
like
more.
the 2nd of February.
Do we just have to, just our ped intubation is the only thing we need to get
So
done?
2 weeks.
Nope, you need labor and delivery stuff that we're doing, Thursday.
Did I mention in my message that you guys, if you're getting ready to go in the OR, you should grab Kris or Doug or somebody to get some practices in and have them check you off and just say, hey, how do I look?
Yeah, they ask us what.
So just to follow up on that, don't ask how I look or how I'm doing. Just be like, hey, am I allowed to go? And then I'll make that. We'll say.
There you go.
Don't ask like, hey, does this look good? Doesn't look good, but you're good enough to go try.
And have they question me a lot on drugs too, so know your drugs and you're like, you're gonna use stocks. What's the contraindications? Hey, what's about this? Because I'm just saying. They'll
Well,
ask
they
you
looked at
too.
Dustin and they're like,
So that's a total serious thing. So when I was in there, I was watching it was a crazy thing. So this kid had I called it an inverted sternum. It's some sort of natural thing that happens. Basically,
Barrel chest.
no,
No.
the sternum is depressed. So they were going in, they snapped every rib off the sternum, put in this giant metal rib cage thing, and then they were reattaching stuff to it.
Iron Man.
It was crazy bizarre, but so I was like, hey, this is a cool surgery. I'm gonna hang out and watch for a little bit because I didn't have anything for an hour. There were no more surgeries because they all started at the same time. So I'm like, ooh, I'm gonna hang out and watch this one for a little while. So I'm watching, and the surgeon starts quizzing me on anatomy of like the pleural cavity and stuff like that. And he's like, so as I'm doing this, take a look at this layer. I'm just like, he's like, so where would this be in the body? I mean, back then I knew it, but like now, now I'm like, it's inside the chest. Is that where the air could get trapped? Somewhere in there, right? But no, like, so like legitimately go in there, like prepared to answer questions. And if you don't know, be like, sir, I'll look it up and get back to you if you like. Right?
Yeah.
Or ma'am.
They don't want you to get back to them. They're just trying to be like, I'm doing my thing, hey. Yeah. They especially like to make you squirm. Right?
I think
I
the
do a lot.
anesthesiologist I was with was more interested in like,
Getting you out of the room.
no, our side drugs, like the order and everything. Cause he kinda looked at me like, you only use ketamine for 3 different things?
Yep.
Cause
And they-
here he was like, we use ketamine all the time, it's the one that we use.
You're like, yeah, my instructor, and that's what he said. I can't use it at all. No other times.
And about 2 years after you guys all get jobs, you're gonna be
It'll be
using
different.
everything like they are now.
It'll be
It's gonna take
different.
some time.
Yeah.
We don't. They use 1 milligram per kilogram for sex. We use 2, and they're like, that's a lot.
Yep. That's when you're like, so are we gonna over paralyze them? And then they're like,
And she's definitely like, yeah, I get why you do that.
yeah.
So,
That's why. So have you guys found that they give low dose, like rocuronium or becuronium before they give the sucks? They give a little bit.
yeah, they pre-medicated. They propofol. They do a little propofol, a little rock, and then a little more propofol, and then the rest of the rock.
Yeah.
And they said it's a loading
so the
dose.
idea behind that is to eliminate the big vesiculations that happen, and basically it just becomes this so like you're like watching and be like, okay, Dave, now stop breathing. So like with us, you see the vesiculations, they do a little you're like, I think we're good. Check the eyes, yep, okay, yep, all right, yeah, we're good to go. But with them, it's just like, yeah, they just, a little bit of this, a little bit of that, a little paralytic,
Yeah. They
nice
say
comb.
faster induction, less time you have to wait, and all that good stuff. They're saying.
Does anyone have just 2 rubber band shifts scheduled?
For OR.
For OR, for OR.
Yeah.
Anyone just have rubber band?
Yeah.
I don't
Does
remember.
anyone just have Mackenzie Willamette? I'm really concerned about those numbers. So.
And McKinsey?
Yeah,
How many did you get?
Mackenzie,
One.
and I got 1.
Yeah, both of yours.
I mean, the funny thing was, he was like, if you come tomorrow, we have like 20 surgeries. And I was just sitting there going like, I had class.
Just a slow day.
Yeah,
Skipping class. Well, it's good to know, just moving forward.
but he was saying like Mondays and Fridays during the beginning of the year are gonna be slow. So most of the bulk of their surgeries, he looked at the
So
schedule.
the only days we can do it.
Yeah, they seemed like they,
You know what you need to do is you need to get them in the OR during, right before the end of the year.
Yeah.
Because end of year insurance.
Hopefully, we won't be here.
Some of you will be here,
Oh.
Take the pants off.
especially when you take your pants off in class.
That's not added points?
No, that's like effective domain.
Yeah, that's sexual harassment.
Right.
He was accelerating the learning dynamic of the group.
No?
No.
I think we talked about this. It's all about how it's interpreted. I interpreted it a whole different way.
How cold was it?
It was really cold. I just got out of a swimming pool.
And what you put.
Why would you use it as diagnostic? Like, how
It's not difficult. It's not difficult. It's very easy to find once you figure out where it is. But I watch people not knowing where to go for it, and it's comical. Like you'll get people way inside here trying to find it. See? And so like if you just use the angle, the triangle, straight up, basically right where the pocket is, and then rotate your fingers in towards the groin region, you'll find it every time. So it's not hard. What's that?
even on bariatric patients?
Yeah, you gotta go a little deeper.
Yeah, in between the apron and That's usually when I'm checking pulses for cardiac arrest, that's where I check. That's my go-to for this.
The femoral? Why?
Stronger, I feel it better, it's stronger to me than feeling a neck or a wrist.
Do you find it faster than a
I
neck?
do. I think I can find it pretty doing CPR, and you're good.
It's funny, I just had an instructor tell me not to find it.
That's fine, what?
Chris?
Not to find it in CPR, because most people don't know how to find it.
Right. He didn't say not try and find it. I said it's funny watching people try and find it.
That's what it was.
I didn't say not try and find it. Now that you guys are coming from LCC, you guys will know how to find it. But it'll be fun if I ever run a code with you and I watch where you're looking for it. I'll be like, oh, I know for a fact. I taught you something completely different. Now I know you weren't listening the whole time.
What are we talking about again?
Right? Exactly. Thank you, Derek, for derailing where we were at.
I'll be around.
Thanks, Derek.
So everybody's totally good on finding femoral pulses? Solid. All right.
Better
Brachial
than I was
pulses.
10 minutes ago.
Everybody good to find a brachial pulse? Don't grab yourself. Everybody can find it on themselves.
You want to check my jacket?
What's the idea behind finding the brachial pulse? Get your fingers up underneath the bicep. All right? Find the crease where the bicep comes into the inner arm. Push up and in.
Let's have it. I'm not flexing. I'm not doing that. Sweaty, dude.
Sweaty?
I'm not judging you, but like, oh, yep.
Bounding is right below, like, you know.
Yeah, it's right below your bicep. So bicep, find the bicep where the crease in the bicep is, push up. Basically, you're pushing up on the bicep. Okay? So, larger people, you got a lot more tissue and stuff to push up out of the way, right?
Nice
I'm
pulses.
gonna say it's reverted. It just sounds funny. Nice pulses. Dang, it's just like the veins. I'm like, dang, you got good veins, bro.
If you have a hard one to find, share your vessels.
Dude, that's how I like to do it. Little beat. It's just so much muscle you gotta
I
like
wonder
sit
if,
through.
does it help to keep the inner arm?
It's right there. It's on it.
Do we use our thumb?
No.
Why not?
You have a pulse here.
So you're saying you guys don't have pulses in your fingers?
We do.
They're stronger.
So if it's your first code and you're feeling a pulse, and it's a weak pulse, it's the first time you've ever ran a code and you're the paramedic, what would my concern be for you?
Are you feeling your own pulse?
Right. Yeah? So legitimately, even to this day, if we were working hard, we had to pack somebody out of a house, do something like that, and then you go to check a pulse, and it's a really, really weak pulse, I'm like, okay, I feel a pulse, but I'm having a hard time differentiating between whether or not this is their pulse or my pulse, right? Because we just carried the person out, and so your blood gets flowing a little harder, right? So how do you differentiate between your pulse and their pulse?
Whoa, that was cool.
Don't use your thumb.
So this is an instantaneous thing.
You feel your own pulse while you're feeling that.
Well, the other thing you can do is you can look is this pulse that you're feeling, and you just take a glance at the monitor. Are they the same? Or is this person bradycardic and, wow, I'm feeling like a 120 pulse here. It's like, oh, maybe I'm a little more out of shape than I thought I was, right? So it's that kind of thing where you just take a quick glance at the monitor. Now if the pulses are close, now you're like, okay, let's figure this out. Somebody else check. I'm like, I'm pretty sure I got a pulse, but somebody else double check that pulse for me, okay? See, I'm I just did the whole Verizon thing, so I'm 8 episodes into that thing.
I got big muscles.
It's a good Game of Thrones.
Waiting, it's like 2 years.
I started watching it, but I've read
First season, 8
Ride the bone.
but we just got that HBO Go for 3 months, so I gotta crank them out on the treadmill. So, no, I do a stair step.
But I want to watch it. It is on my list. Just wait until this season.
Okay, we're good there. We're good with finding pulses. Yeah, how do we differentiate between a fracture and a sprain or a dislocation?
X-ray?
Movement.
What? Oh my God, wow.
Pinpoint versus diffuse
Range of motion.
Range of motion test. Is somebody with a sprain and a fracture going to have difficult range of motion? Okay. Deformity. Can somebody with a sprain have a deformity?
Yes.
Are the deformities the same?
No.
Do they look the same?
No.
Depends
Okay,
on.
so I'm gonna back this up a little bit. So we have obvious fractures where your like ankle is like pointed this direction, right? That's an obvious either dislocation or fracture, right? But let's just say you have just swelling around the ankle, right? Somebody slipped, fell, boom, down they went. They're like, "Ooh, I felt a pop," and now they're sitting in their chair when you get there, and their ankle is like the size of a grapefruit. Okay? Fractured or not?
X-ray.
You don't know. What type of pain is it?
Well, they're like, what do you think? Do you think it's broken? What do you think?
Can you point to the pain? Right where it hurts?
Right there in my ankle.
Is it
See
right
that big
here?
swelling
Is it on the
thing?
inside or the outside?
It's hard to tell. I have
So-
really bad sprains.
So
Yeah,
the funny
it's
thing is I
really
used
bad.
to tell people, I'm just like, oh, you know what? I'm guessing this is a sprained ankle and you'll be in and out in no time, right? And then I'll see something and I'll be like, oh man, this is definitely broken. I was like 0 for like 20 on guessing. I kid you not. I was just like, so finally now what I do, I'll be like, okay, so they'll ask me, because every patient wants to know. They're like, oh, what do you think? Do you think it's broken? Do you think it's broken? I'll be like, normally I'd say yes. But I've been doing this a long time and I'm really bad at making this determination. I was like I'm less than 50%, so I'm saying yes, so that means it's probably not. And they're like, oh, thank God. I'm just like, I know, that's how good I am at like, legitimately, like, there's really no, if it's not obvious, like, you can try the taps on the bone. Taps on the bone is a decent try. So if you have somebody with a potential dislocation or a fractured hip, Noah, boom, hop up here again.
You're the patient of the day.
Oh man, a little pep in your step though. Let's go. So say he's got some hip pain, upper leg pain, and I'm trying to determine if it's dislocated or if it's a fracture, or if there's nothing wrong at all, right? So there's no obvious deformity, but he's got some pain in his hip, right? So some of the first things that I'll do when I'm assessing it is I'll grab him here. Obviously I'll start low, I'll palpate all the way up, no real pain, only pain on movement, okay? So we'll grab it and we'll just start slight like range of, geez, please, dude, stop resisting. So slight range of motion test, okay? So to start off, you want to keep everything straight, okay? You don't want to try any sort of rotation, anything like that, because the first thing you want to do. So I'll come up, I'll do this, I'll bring it back down. Next thing I'll do is I'll take the bottom of the heel, and I'll tap on the bottom of the heel. What's that going to tell me?
With the boot or without the boot?
I take the boot off.
Yeah.
You're taking the boot.
Just making sure.
So before I did any of this, I checked my pulses, I checked my sensation, I checked my CMS before I did any assessment on that. Okay, so what am I doing when I'm tapping the bottom of the heel? What does that do?
It sends pressure up the bone, and if there's any breaks, they're gonna rub it.
Exactly. So when you tap on it like that, the pain becomes a sharper pain. Okay? A lot of times if it's just dislocated and you tap on it like that, it's more of a dull, like, yeah, that kind of hurt a little worse. But if you tap on the end and it's legitimately broken, they get that bone-to-bone tapping running together, and it becomes more of a sharp style pain. Okay? So we do that test, not a lot of pain. Okay? He's got nothing there. Okay? Next thing I'm gonna do, I'm gonna move over here, but normally you're on the outside doing it. So you're gonna bring it up to here, and then you're gonna rotate it around like this. Okay? Try and rotate out. Any sort of pain there, boom, we come back to natural position, anatomical, bring it back down. Okay? So if I can do all of those with minimal to no pain, what do you think?
Sprain. More likely sprain than fracture.
Right. So if I go like this, and we're good to go, yep, no pain, no pain, no pain, boom, I do this, and they instantly are like, ah.
Dislocations?
If it's dislocated, I'm not even gonna be able to do this.
Okay.
If it's dislocated, I'm gonna go, whoop, and they're gonna go, whoa, and they're gonna instantly have pain, right? Because you're gonna have resistance. Because if it's dislocated, you got this femoral head that's out of place, depending on if it's anterior or posterior, that is now basically just shoved into the tissue space, right? Into the cavity there. So as soon as you